Hello, and welcome to this webinar by FUJIFILM Sonosite. My name is Stephanie Doniger, and I'm a pediatric emergency medicine physician. I'll be speaking with you today about pediatric point-of-care ultrasound and the use for soft tissue applications. This is actually one of the most common applications that we use in the pediatric population. Our objectives for this webinar: I'll give you a brief overview and discuss the applications for soft tissue. We'll go through case presentations for each of these applications. We'll describe the techniques for each of these applications, and within each application, the limitations and scanning tips. So we often have pediatric patients coming in with cellulitis and abscesses. It's often difficult to distinguish whether it's just cellulitis or abscess, which ultrasound can help us for that. But also foreign bodies. So foreign bodies can be particularly challenging, and ultrasound can help us determine whether a foreign body is present. And if there is, it can actually help us prior to incision and drainage. For imaging of soft tissue, it's preferable to use a linear high-frequency transducer. And this is because the majority of the structures are very superficial in nature, especially in pediatric patients. Now here, you can see a variety of transducers that are high frequency. The one in the front is the hockey stick transducer, and that is actually a higher frequency which can be utilized, but generally all of these can be utilized for these applications. Now, it is important in pediatric patients and with superficial structures to adjust the depth accordingly and to use adjuncts. Here's an example of depth. So now here's a patient with a chin abscess, and you can see here on top that here's the abscess, but we have all of this wasted space. Now, when you have the structure way up here and you don't adjust the depth accordingly, it's very difficult to see the details of that abscess. Now, when we actually decrease the depth on the right, now you can see that there's much more detail, and you can see the extent of that abscess much better with, again, better detail. We can use adjuncts, especially with these superficial structures, to help the imaging. Now, if there's a patient who has either an abscess or a foreign body in the hand, a water bath is actually quite helpful. This can be used in the feet as well, but it's technically quite limited and difficult. Now, note that you don't actually have to touch the probe to the patient's hand, which actually helps with pain control as well, since you don't have to directly touch the region of interest. Alternatives to help you image these superficial structures are standoff pads. Now, there are commercially available standoff pads that you can see here that are rather costly, but we can actually make our own very easily with a saline or tap water filled glove. Just make sure that you actually put gel in between the probe and the glove, and then also between the glove and the patient's hand to improve imaging. The reason why these adjuncts are important is that we want to actually image at the focal point. So when we increase that depth between the transducer and the structure of interest, our structure of interest will now actually be in the focal zone, and we'll have better imaging of that structure. This is what it looks like. It's important to be familiar with the structures that you'll see on ultrasound. Now, it's not as important to tell the difference between all of the different layers, but it is important to recognize that this dark on top, this is the fluid, this is the in between the probe and actually the skin itself. This hyperechoic line is the epidermis. We can see hypodermis, and we can see muscle. Now, bone will appear hyperechoic of the anterior cortex and have posterior shadowing. And this is what it looks like side by side with a water bath. We have a patient's hand here. You can see prior to the water bath, you can barely see this little structure here. You can kind of see a line. It's quite difficult to image. I have put a fair amount of gel in between the probe and the skin in attempts to image the structure appropriately. However, what we can see here is that once we have the hand in the water bath, here's the water of the water bath. You can see this foreign body very easily, and you can see the detail and the extension into the subcutaneous layer much better. So you can have a lot better detail with the use of a water bath in a hand. So when we're dealing with sterile procedures, this is the case for any sterile procedures, it's important to prepare the probe in a sterile fashion. Now, you also have to remember that in order to create an image on the screen, the ultrasound probe needs to have gel on top. So we can start with our regular gel that comes in the bottle that we're all used to, but then you actually don't want to put that onto a sterile field because it is not sterile. You'll have to now cover it with a sterile sheath. There are commercially available probe covers that have a kit that have everything you need inside. It has a cover that goes over the transducer itself and extends over the cord, which is ideal. Therefore, this will not contaminate your sterile field. It also has rubber bands and sterile lubricant to put on top. Now, if you don't have the luxury of having these probe covers, you can actually put the probe inside of a sterile glove, but be careful because this area of the probe is not covered and that can contaminate your sterile field. Now, once we've put the sheath on top, we need another layer of gel, but we need to use sterile gel. Now, you can use those sterile lubricant packets. Those do come within the probe cover kit, but also you can use the traditional packets that we used to perform rectal exams, which we're not doing as many in pediatric patients. So now on to the actual applications of soft tissue ultrasound. This is actually quite common. We have an 18-month-old female coming in with what mom reports as a spider bite to her left buttock. It has become progressively larger, more painful, and the child now has a fever. Examination is very difficult, as it often is with children this age, but what you can tell is that there's a region of about 4 by 4 centimeters of erythema. There's some induration and a central papule. So we can probably tell that there's an abscess based on that exam. We're probably pretty suspicious that there's an abscess, but oftentimes what happens is we're not sure if we actually can perform an incision and drainage at that time, whether that abscess is ready to have an incision and drainage. Now, the most frustrating thing and the most resource costly thing is to actually perform an incision and drainage when there is no abscess present. So particularly in this age group, in an 18-month-old, you would have to actually have the patient sedated in order to perform the incision and drainage. So ultrasound can help us identify whether an abscess is present. So we can see here, we immediately see the structure in the center that is anechoic, so that represents some fluid, but it's actually not as large as we were expecting. So that is a very small abscess with some surrounding cellulitis that actually I would not perform an incision and drainage at that point. So cellulitis, we all are very familiar with diagnosing cellulitis. It's a clinical diagnosis. You don't actually need ultrasound to diagnose cellulitis, but ultrasound is needed when you're not sure whether there's an abscess present or not. The technique, we're going to use the linear high-frequency transducer as we do with all of these soft tissue applications. What I usually recommend is starting at the region that's unaffected of normal skin, orienting to the normal skin, and then scanning over the entire affected region. Then once you've performed this scan, you're going to rotate your probe 90 degrees and scan in the other plane. Again, beginning where there's an unaffected region, scanning over the affected region. Now, if there's a region in the center that's a papule or is particularly indurated, I tend to focus on that area, really looking to see if there's an abscess that's present there. Now, what we'll see on ultrasound, what I can show you on this side with normal skin anatomy, it's not important, as I mentioned before, to know the different layers. It's interesting to see, but it's not important other than to know that normal skin anatomy has nice clean layers. Now, this is in contrast to cobblestoning, where you see here, this does not have clean lines. You have globules and you have edema surrounding those globules. It's referred to as cobblestoning, which you can see here below. These are cobblestones. This is pathognomonic for cellulitis. Now, early on, you may not see the very apparent cobblestone that we saw in the last example. Early on, you can see this area is just quite hazy, and you can see stranding, vertical lines. These are called hypoechoic stranding, and that is an early sign of cellulitis. Now, as we progress through cellulitis, you can see the development of the globules or those cobblestones and surrounding edema. Now, this anechoic fluid that surrounds the cobblestones is not an abscess, and that can commonly be confused for an abscess. As cellulitis progresses, you can see there's much more fluid, and it's much more apparent here. Now, it's important, especially if we're not sure whether our findings on ultrasound are normal or abnormal, it's important to compare to the unaffected side. So we luckily have 2 arms, 2 legs. We can compare the affected and the unaffected side. In this example, this is a side-by-side comparison of a right calf. This is normal. We can see those nice clean lines. And this is the left calf that has cellulitis. You can see the cobblestoning. There's disruption of that architecture, and it's also hyperechoic or bright white when compared with the unaffected right side. Now, this may not happen very often, but it's important to recognize that you may have a patient with necrotizing fasciitis. That is not the typical pattern of cobblestoning, but what you can see here are very dirty, scattered shadows, and that's air within the subcutaneous tissues. This is obviously a very time-sensitive and dangerous diagnosis, but if you see this on ultrasound, then you need to take action appropriately. Now, as I mentioned before, it's often difficult to distinguish cellulitis from abscess. Ultrasound can help us with that, but also it has treatment implications. So if we're to perform an incision and drainage, we can identify surrounding vascular structures and neurovascular bundles to avoid those for incision and drainage. The technique, as I mentioned before, it's the same for an abscess as it is for cellulitis, because really we're looking to see if there's a presence of abscess. We're going to start in the area that's unaffected. We'll scan over the area, spend some time over that area of greatest fluctuance, and scan in 2 planes. Now, once you find an abscess, it's important to measure not only the size, but the depth if you are to perform an incision and drainage. And as I mentioned, it's important to identify surrounding neurovascular structures in order to avoid those if you are to perform an incision and drainage. Now, what do abscesses look like on ultrasound? They can look like a lot of different things. They're not always anechoic or perfectly dark. They may be anechoic, they may be hypoechoic, there may be internal debris, but because of fluid inside of those abscesses, there may be posterior acoustic enhancement. Now, in order to identify abscesses, especially if they happen to be isoechoic with the surrounding tissue, oftentimes you can use compression to see if the pus moves, or you can use Doppler. Here we can see a small abscess, a very tiny abscess, that if I were to find this, I probably would not perform an incision and drainage. All I would do is perhaps warm compresses and topical antibiotics. Now, as we progress, we can find larger abscesses. Here's a situation where you have a quite large abscess. You may be confused and think initially this is only the abscess, but you must look carefully and see the entire region. This is an example how you can have different echoes within that abscess. And as you progress to larger abscesses, you can see here, this is the abscess, and it's important to measure both the depth and the width. Here's another example of an extremely large abscess here with posterior acoustic enhancement. And once you find a very large abscess that you're going to perform an incision and drainage, you can further measure the distance from the skin down to the entrance of the abscess. You can either measure it this way or estimate the depth based on the right side of the ultrasound image. Here's an example of an extremely large buttock abscess. As you fan through, you can see anechoic fluid, but then you can see this isoechoic and slightly hypoechoic tissue. This is still part of the abscess, and you can see loculations inside. Now, here's an example that's actually quite common, that you have a smaller footprint transducer, that's a linear transducer, and you see this large abscess. Now, if I were using this transducer, it would be extremely difficult to measure and fit it because you can't fit it all on one screen. So in this situation, you would need to change to the lower frequency transducer in order to get an appropriate measurement. Of note, this is a pilonidal abscess. You can see here the depth of the abscess and the width. It's quite large, almost 6 centimeters. Obviously, if I found that on ultrasound, that I would need to perform an incision and drainage or call my surgical colleagues. Here's another example. We have a very small abscess here. Again, if I found this is a very small abscess that I would not perform an incision and drainage. If it were uncomfortable, perhaps I would do a needle drainage, but that's the most that I would do in this situation. Here's an abscess. What you can do, as I mentioned before, is use a technique called graded compression with the probe. That's actually performed here. You can see movement or swirling of the pus. This is especially helpful if you have an abscess that's isoechoic with the surrounding tissue. Once you see movement, you're pretty confident that that's an abscess, and you can refer to that as pustosis, or movement of pus within the actual abscess itself. Here's a case that I had in the emergency department. This is a 14-year-old girl's sacrum. She had actually been in the emergency department the day before, and the clinician had thought that there was probably an early abscess present, but it wasn't ready for incision and drainage quite yet. The patient returned because she had quite a bit of pain, and you can see this region here of erythema and just a little bit of swelling. We immediately put the linear transducer on the patient, and you can see this large area of fluid. You can see some surrounding cobblestoning, but this is a very large fluid collection. Now, it is important to note that this does look a little bit different than the patterns that we saw before. You can see these dots swirling within the cavity of the abscess. This is cystic fluid that represents those dots, and that's super infected. So it is pretty typical for a super infected cyst. Now, once we find an abscess that needs to have incision and drainage performed, we can use ultrasound to identify both the ideal location for performing incision and drainage, and also identify surrounding neurovascular structures that we don't actually want to cut into. Now, generally for abscesses, we use the technique called ultrasound assistance, and this is skin marking prior to performing incision and drainage. We don't actually use ultrasound during the incision and drainage itself. You can also repeat the ultrasound following incision and drainage to make sure that you've actually opened up and obtained all of the pus within the cavity itself. So here's an example that one of the fellows presented to me. This is a patient who had axillary swelling and pain, and I was a little bit hesitant to perform incision and drainage. We did the initial ultrasound here, and you can see a relatively large abscess. So we didn't measure it, but you can estimate based on the depth on the right side of the screen. This is at least about 1.5 centimeters deep. So it's actually a quite sizable abscess. However, the reason why I was hesitant to perform an incision and drainage in this region is that the axillary region has a lot of neurovascular structures. And here you can use color Doppler. You can see the flow right through the center of that abscess. If we had actually performed incision and drainage, that patient would have had significant bleeding and complications as a result. So therefore, we actually opted not to perform incision and drainage. We decided to have conservative management with warm compresses, topical antibiotics, and because of the surrounding cobblestoning and cellulitis, we gave her oral clindamycin. Here's another example of a buttock abscess. This was a patient that had swelling, tenderness. We can see the abscess here. The patient's moving around a fair amount. And you can see the swirling of the pus with movement of the probe itself. This actually was a communication of the abscess with the rectum. So there was a fistula, so we needed to call the surgeon. This was also another example of an abscess that we would not perform an incision and drainage based on the ultrasound results. So I'm obviously a fan of ultrasound and point of care ultrasound in the emergency department, but I'm not going to use ultrasound when it's not going to help me clinically. It's impossible to take the time if it's not going to actually impact your patient care. So if it's pretty obvious on exam that a patient just has cellulitis or conversely just has an abscess, I actually don't use ultrasound. It's those ones in between. So this is the algorithm that I employ. If there's a very clear abscess on exam, I put a needle in it or I perform incision and drainage. If there's no abscess, if it's just cellulitis, then I treat with antibiotics. And that's pretty easy. But it's really those ones in the center, those ones that we're not sure if there's an abscess present or whether it's just cellulitis. If we performed ultrasound and it's positive for an abscess, then we can therefore go ahead and perform incision and drainage. And if it's negative, then we would treat for cellulitis. So we can also have abscesses in unusual locations. Now this is a particularly difficult case that I had, 2 separate cases of swelling in the pinna, which can be an emergency as far as the cartilage itself. If there's an abscess present, it needs to be promptly drained because it can cause a pressure necrosis of the cartilage. So when obviously these cases always come in the middle of the night, I needed to call my ear, nose, and throat specialist. And his first question to me was whether there was an abscess present. And clinically, especially the patient on the left here, it's really difficult to tell whether there's a fluid collection present, whether I needed to actually call him in from home in the middle of the night. So I performed an ultrasound. Now, I had previously never done ultrasound of the pinna, and I didn't know what it was supposed to look like. So this is the affected side. Well, we can compare it to the unaffected side. So you can see here in the unaffected side, we have hyperechoic cartilage. You have nice clean lines around that cartilage. And when you compare in the same patient, here's the cartilage, and you actually have a very thickened subcutaneous tissue. And you can see this anechoic fluid collection. So this was indeed an abscess that needed to be drained by ENT in the middle of the night. There are some things that can fool you, and they're mimickers for an abscess. The neck is particularly difficult. This is a patient who had neck swelling. You can notice here that there's neck swelling with overlying erythema, and it's difficult to tell whether that's an abscess or not. When we actually perform the ultrasound, we can see here that this is a lymph node. In our patient, it's enlarged, but you can see it's very regular. There's a central hilum. There are no anechoic irregular structures inside. So this is just an enlarged lymph node. So that could actually clinically make you confused for an abscess, but on ultrasound, it's obviously not something that we would perform an incision and drainage on. This one fooled me. This was a patient with swelling, and you perform ultrasound and you can see here that looks like cobblestoning. That looks like here that might be an irregular fluid collection of an abscess. When I actually performed incision and drainage, this was not an abscess, but it was a hematoma. So hematoma can look very similar to cellulitis and abscess. So be careful and use your clinical history and physical examination findings in conjunction with your ultrasound. This was another child who came in with leg swelling. You can see here that there are some abnormalities of the subcutaneous tissue. You can see some of that hypoechoic stranding and maybe some early cobblestoning. That last patient was actually a bug bite. This patient also with leg swelling, you can see it looks a little bit hazy in the subcutaneous tissues. This was actually not cellulitis, but it was a vaccine reaction. So you can see reactions, whether it's an allergic reaction in the prior case or swelling after an injection or vaccination. Those should not be confused with cellulitis. So the findings of cellulitis are pretty nonspecific. As I mentioned, a hematoma can look like cellulitis, bug bites, vaccine reactions. So really cellulitis is more of a clinical diagnosis. What we're using ultrasound for is to identify the presence or absence of an abscess. It's really helpful to use compression, look for that peristalsis to see if there's fluid inside, look for adjacent structures, and compare to the unaffected side. Now, this is actually one of my favorite applications because I absolutely hate foreign bodies. I hate hunting for foreign bodies, and I particularly hate foreign bodies under the nail. So this was actually a patient with a suspected foreign body, and I performed ultrasound to prove to the mother that there was not a foreign body, and I was wrong. So be careful when you're using ultrasound to rule things out. We really want to rule it in, and luckily I actually did rule it in for the patient. So this particular patient was a 13-year-old male who fell against a wooden dresser. He felt that part of the wood actually went under his nail, but given the fact that he was a teenager, he wasn't really sure if the piece of wood was still under his nail, but it hurt and it looked like this. So you can see this line underneath the nail, and it was hard to tell whether that was a foreign body or not. So because it was in the hand, we put his hand in a water bath. And you can see here, we can see his nail. This hyperechoic structure posterior, this will loop through, is the phalanx. But if you look just under the nail, you can see this hyperechoic line that extends past the eponychium here, and that is the whole foreign body. So we removed it, and it was almost 2 centimeters. So that was actually a really good example of using a water bath to identify a foreign body. Now, foreign bodies can be very easily identified. The technique is very similar to what I mentioned before for cellulitis and abscess. You use a high-frequency linear probe. If there is open skin, as there often is, be careful and make sure that you prepare the probe in a sterile fashion. Patients will often have a puncture wound or an area where they feel like there's a retained foreign body, so you really want to focus your interest there. Start in the unaffected area, scan over the affected area, really focus on that affected area or whether there's a puncture mark. Then rotate your probe 90 degrees and scan over that area of interest in your second plane. Now, foreign bodies are often very difficult because we have relied historically on using plain radiographs to identify foreign bodies. We all know that the only things that will show up on radiographs are glass and metal and sometimes gravel, but there are tons of other foreign bodies like wood, thorns, plastic that will never show up on plain radiographs. In addition, radiographs involve ionizing radiation, and this is something we obviously want to decrease, the exposure of ionizing radiation in our pediatric population. So ultrasound is great in identifying foreign bodies. Almost every foreign body is hyperechoic or bright white. So whether it's radio-opaque or radiolucent, they're almost all hyperechoic. Now, there are certain artifacts that can help you identify foreign bodies, what types they are. Metal will have a ring-down artifact, and some of the more dense materials will have posterior shadowing. In situations of retained foreign bodies, there can be a hypoechoic halo surrounding that foreign body itself. So here's an example of a foreign body. As we scan through the subcutaneous tissue, we can see this tiny little dot here. This shows the importance of scanning in at least 2 perpendicular planes. When you rotate the transducer into the second plane, you will now see the entire length of this foreign body here with that ring down artifact. This is a situation of a needle. Now, if you had only obtained that first view, you could easily miss it. It is important to note that very small diameter foreign bodies may be missed by ultrasound. Here's that hyperechoic foreign body with that ring down artifact, those parallel lines, and that signifies a metallic object. Of note, this is actually a needle that's in the patellar ligament that you can see here. As I mentioned, there are particular artifacts that can help you The ring down artifact of metal you can identify. Now, sometimes you see the artifact first before you actually see the foreign body. Here's an example in the center of a very small foreign body, but you can see the posterior shadowing. You can see posterior shadowing with glass and less commonly plastic and wood. There are other things like wood that will have a very dense hyperechoic nature, but you won't see that ring down artifact or you won't see that dense shadowing. So again, keep in mind that almost all foreign bodies are hyperechoic. Here's an example of a glass foreign body. You can see this line coming down here and perhaps this hyperechoic area. Very important to obtain two views. You can see the posterior shadowing deep to that. Here's an example of a splinter. On exam, there was barely any splinter that you could see once you put the patient's hand in a water bath. You can not only see the splinter here, but the extension deep of that very large foreign body. And this foreign body was more than a centimeter that we retrieved. Obviously says it at the top, and you have the picture here. This is a very large splinter that we retrieved from a patient's thigh. You probably wouldn't miss this, but this is often really difficult to tell where you should perform your incision and drainage. Now, in the transverse view, as we're scanning through, you can see the shadow marching up. These are various cross-sections of the splinter itself. One other thing that you can do to help identify a foreign body is injecting lidocaine surrounding that foreign body. So if I have a foreign body that I'm not exactly sure where it is, I can identify it first on ultrasound. With ultrasound guidance, inject lidocaine surrounding it. Anytime there's fluid that you introduce, it acts as an acoustic window. So what you can see here is the foreign body and then this hypoechoic halo around it. This appearance is also the same if it were a retained foreign body. So in order to remove a foreign body, oftentimes the easiest thing to do is just ultrasound assistance. So identify the structure on ultrasound, mark the skin, and remove the foreign body without the use of ultrasound. Alternatively, especially if you have a foreign body that's really difficult to remove or something round that is moving as you're trying to remove it, ultrasound guidance can be helpful. So you can actually see the foreign body moving in real time. One of the tricks that you can do for ultrasound guidance, particularly if it's a difficult foreign body, is identify the foreign body on ultrasound, introduce a needle with ultrasound guidance, and have the needle extend down to the foreign body, down to below the foreign body. Keep the needle in place, remove the probe, and then you can incise down to that needle that you kept in place because your foreign body will be just on top. Additionally, you can use ultrasound and look at forceps directly themselves. So it is important to remember that ultrasound is quite limited in detecting small foreign bodies. It depends on the orientation of the probe to that foreign body. Sometimes, especially in the foot, if a patient steps directly on a very small diameter toothpick, let's say, if you scan in two planes at the bottom of the foot, you'll only see that very small diameter. Now, if you do an additional view on the side of the foot, you can now see the length of that toothpick and identify that foreign body. One thing to note that if you have a patient with a suspected foreign body in their hand, be very careful because a lot of the small hand bones can be mistaken for foreign bodies. I had mentioned different techniques for removing foreign bodies. This is the example of needle localization. You can see the foreign body here. We extend the needle down to the foreign body. We leave that needle in place and we can incise down to that foreign body itself. Here's another example. This is in real tissue. We have a foreign body here. We extend the needle down. We'll leave that in place and we'll incise down to the needle. We can use forceps. We can look in real-time guidance. We can see the foreign body here and the forceps grabbing. Now remember, because this is a metallic object, that not only will you have ring down artifact from the metal, but you won't see both sides of the forceps because they're very dense. So you will see the anterior portion of the forceps and you can see the tip actually grabbing the foreign body. Here's an example of foreign body again in the hand. Here's that thorn. This is the example that you can just see barely any of the wood of the thorn here. When we use the water bath, it extends here. This is hyperechoic, extending deep. And this was the foreign body that was more than a centimeter. This was an example of a pencil in a foot. So we did use x-ray, you can see it here, but it's often difficult to identify exactly where it is based on x-ray. We can identify that it's there, but not necessarily where the location is. So here we can see the hyperechoic foreign body with posterior shadowing, and this is the large pencil tip that we extracted from the foot. So I encourage people to practice identifying foreign bodies. It's actually quite easy to make phantom models and practice this technique. Here we have a few different types. We have chickens that we put phantoms, different materials of wood, metal, there's a safety pin, and then some plastic. It is helpful to have a map of what you put in there so people can identify. Polenta is a good alternative, or gelatin and Metamucil models. So here we are. We had a few courses with WinFocus where we had various gelatin and chicken models. And here are those gelatin models. It's helpful to practice to identify what these abnormal patterns are on ultrasound before actually scanning on real patients. So in summary, for these soft tissue applications, which are extremely helpful in pediatric populations, we're going to use the high frequency linear transducer. For cellulitis, we're actually not using ultrasound to diagnose cellulitis, but we're looking to see if there's a fluid collection or abscess. We're also looking for foreign bodies. All of these techniques, you want to make sure that you scan in at least 2 planes, look for surrounding neurovascular structures, and you can really extend these principles to other applications. As I showed the example in the neck, you can identify abscesses in the neck and other locations that you may not necessarily be familiar with. And the other example is the cartilage in the pinna, that the same principles of an abscess will extend to those other locations. As you practice these exams, as you look in phantom models, as you practice on patients, you'll find that actually these are amongst the easiest of ultrasound exams. They're also the most helpful in your management of pediatric patients. Thank you so much for watching this webinar. If you have any questions or comments, you can contact me. My Twitter handle is here. And also, if you'd like to learn about other pediatric point of care ultrasound topics, you can refer to the textbook Pediatric Emergency and Critical Care Ultrasound. Thank you very much.